Hi, very good morning. I am Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. All this lecture will be very helpful to fourth year student, exam going students and doctors who are doing practice and to the interns also. Today, in continuity with the previous lecture series on ECG, I am going to talk today on Torsades De Pointes, or we also call as a long QT syndrome. There is another word also utilized for that, that is spin off or twisting of points. This is very, very important because if you pick up this before a person develops ventricular tachycardia and ventricular fibrillation, you can reduce the mortality, because Torsades De Pointes can end up with ventricular tachycardia and ventricular fibrillation. And the type of ventricular tachycardia is different from other variety of ventricular tachycardia. So we'll be discussing little bit on that part also. So it is always a term that more you see and more you listen, you always know more. And from that point of view, we'll be discussing on long QT syndromes and particularly on Torsades De Pointes. So we'll be discussing under all these headings as routine, definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis, treatment and complications. First, I'll be talking little bit some terminology regarding a ventricular tachycardia. Now we know that the meaning of ventricular tachycardia is the complexes are originating from ventricle. So focus is from the ventricle, maybe from right ventricle or maybe from left ventricle. And the rate, normal idioventricular rate is between 30 to 40. But when that rate becomes more than 100, we call that as ventricular tachycardia. If all complex are same, like this, then we use the word monomorphic. And if the ventricular complex are changing, they are of different shapes, different amplitude, we call that as a polymorphic. Meaning that you have got multiple focus. Monomorphic, you have got a single focus. This particular two common terms which are being utilized. Now usually it starts with one single ventricular premature beat, or we call ventricular ectopic. You can have a ventricular two ectopics, we call couplets. When three are together, we call triplets. Or we also use the one non-sustained ventricular tachycardia. And when they are more than three, we usually use the word sustained ectopics or sustained ventricular tachycardia, because the rate is always more than 100. So if it is lasting for more than 30 seconds, we usually term that as sustained ventricular tachycardia, continuous, like this. Ventricular complex are wide complex. They originate from ventricle. The rate, if it is more than 100, then we usually use the word ventricular tachycardia. There are two varieties we call non-sustained and sustained. Non-sustained ventricular tachycardia, shortly we mention as NSVT, where ventricular tachycardia is less than 30 seconds. Either there are three or more consecutive ventricular beats. Rate may be more than 120 per minute, but duration is less than 30 seconds. Classical this. These are 4, these are 5. This we'll call non-sustained. And when you get continuous more than 30 seconds, we call that as a sustained ventricular tachycardia. Then depending upon the hemodynamics, we call stable and unstable. Meaning, when the person has got ventricular tachycardia, which may be monomorphic or polymorphic, but the person has got fall of blood pressure and vital organ perfusion is being affected, we always use the word unstable ventricular tachycardia. And if the perfusion is maintained, then we use the word stable ventricular tachycardia. So ventricular tachycardia you can divide into monomorphic and polymorphic. In monomorphic, regular and all QRS complex are having similar morphology, while in a polymorphic they are irregular and variable morphology, which you can further divide with normal QT interval and prolonged QT interval. We'll be talking more of this. That is what we call as a Torsades De Pointes. And there is one more variety which is called pleomorphic ventricular tachycardia. So difference between polymorphic and pleomorphic is, in polymorphic continuously there is a changing in ventricular complexes because there is a change in the axis or morphology, while pleomorphic is more than one distinct complex morphology during the same ventricular tachycardia but not continuously changing, while here constantly it is changing. Commonest example of polymorphic is acute myocardial infarction, long QT syndrome and electrolyte disturbances, while pleomorphic is more common in a scar related ventricular tachycardia. So polymorphic ventricular tachycardia can be with a normal QT interval or can be with long QT interval. Short form we always use the word TDP, Torsades De Pointes. While a normal QT is called non-Torsades De Pointes. And classical example of that is Brugada and catecholaminergic monomorphic ventricular tachycardia. It is more common with ischemic heart disease, can be primary or can be due to scar. And always we want to find out, is this ventricular tachycardia is TDP, because they will be having a very high chance of going into VF. Now as far as a TDP is concerned, Torsades De Pointes is concerned, congenital, acquired, and among acquired, pause dependent and acquired because of ischemic heart disease. Pause dependent very commonly because of drugs and hypokalemia, and among congenital it is adrenergic stimulator. So this is a classical example of monomorphic, and you can see here the axis is constantly changing. Some complexes are positive, some complexes are negative. So that is called polymorphic. In pleomorphic, they do not change the axis, but morphology changes. And there is one variety we call bidirectional ventricular tachycardia. So one complex is in one direction, second complex is in other direction. So it is called bidirectional. While in a Torsades De Pointes, you get a polymorphic ventricular tachycardia preceded by long QT complexes. The complex is having long QT, and then when it goes into a rate which is very high, then we usually use a word more than 300. We use the word ventricular flutter, and when there is a chaotic QRS complexes where you cannot identify QRS complex, we usually use the term ventricular fibrillation. So monomorphic, polymorphic, Torsades De Pointes, classical. In a bidirectional, you can see that alternate complex are in a different direction. So we call bidirectional. Bit to bit alteration of the frontal QRS axis, and it is very common with digitalis toxicity. And another is catecholaminergic polymorphic ventricular tachycardia. This is secondary due to excessive stimulation by catecholamines. Again, polymorphic, constantly changing the axis, we'll label that as polymorphic ventricular tachycardia or Torsades De Pointes. While this is all complexes are same, so we call monomorphic ventricular tachycardia. Again, monomorphic, polymorphic. Regarding QT interval, if QT interval is long than half of RR interval, then we always mention that as prolonged QT. So, useful rule of thumb, normal QT interval is less than half of preceding RR interval. While QT prolongation, ideally we calculate QTC, that is called corrected QT interval. If it is more than we call 0.44 or we call 440 milliseconds in male and 460 milliseconds in woman, we'll label that as a prolonged QT. Or QTC, if it is more than 0.5 milliseconds, then we will label or we call 500 millisecond, that is having a very high risk of Torsades De Pointes. And if QTC is less than 350 milliseconds, then it is called short QT. Torsades De Pointes is common with prolonged QT. This is normal QT because interval is 380 milliseconds. Prolonged QT is more than 0.5 or we call 500 milliseconds. The chance of Torsades De Pointes will be very high. Here it shows you that there is a prolonged QT. If you look from here till here, this is prolonged QT. If you calculate the QT interval, it is more than half of RR. This is classical polymorphic ventricular tachycardia with normal QT. So you can see positive, these are positive but different complexes, the morphology is different. See this morphology is different. This is polymorphic but the QT interval is normal. Myocardial ischemia, structural heart disease, channelopathies, etc. will be with this type of complexes. Torsada means twisting, pointes means points. So long QT interval, you can see that this is a long QT interval. So usually a short QT is followed by a long QT, again followed by short QT, and then you trigger off a polymorphic ventricular tachycardia that is labeled as Torsades De Pointes. So this is having a short QT, this QRS complex is having a long QT, and then again there is a short. So usually it is mentioned as short, long, short QT followed by polymorphic ventricular tachycardia. That is classically seen in a case of a Torsades De Pointes. So you can see there's are negative complexes. These are different type of complexes. Again, these are more positive. Again, these are more negative. So constantly they are changing the axis. So polymorphic ventricular tachycardia with long QT, we label that as a Torsades De Pointes. So they are rapid, irregular QRS complex and twisting around the ECG baseline, or we call axis. So that is Torsades De Pointes. Polymorphic ventricular tachycardia with long QT. So you will have a short QT followed by a long QT and again short QT, and then you get polymorphic ventricular tachycardia. That will be Torsades De Pointes. This is atrial fibrillation. This is sinus rhythm. This is sinus rhythm with long QT, and there is only one single ventricular premature beat. And there is an episode of Torsades De Pointes. You can see this is Torsades De Pointes. So this is a short QT and Torsades De Pointes is triggered off. So that happens very frequently with short, long, short QT followed by Torsades De Pointes. So the features of Torsades De Pointes is, we already mentioned, short, long, short cycle followed by polymorphic ventricular tachycardia, which will be twisting around the isoelectric line, or we call axis. So changing in amplitude of QRS complex and twisting of the QRS complex around the isoelectric line, and usually there is a short, long, short pattern of RR cycle, short coupled PVC followed by a compensatory pause, and then another PVC that falls close to the peak of the T wave. Usually we use the word R on T phenomena, and then there is a warm-up phenomena and it terminates spontaneously. So frequently terminates spontaneously, in contrast to ventricular fibrillation that does not terminate without defibrillation. So this will start, Torsades De Pointes will start, may terminate spontaneously or may go into ventricular fibrillation, and once it goes into ventricular fibrillation, the mortality rate is very high unless you defibrillate and treat them. So short QT, long QT, again you have got a short QT and there is R on T phenomena followed by a polymorphic ventricular tachycardia. So Torsades De Pointes usually terminate spontaneously but frequently recurs and may degenerate into ventricular fibrillation. So this can recur again and may terminate into ventricular fibrillation. So variation in morphology of QRS complex is from bit to bit. Changing in the axis, that is QRS vector, positive may become negative. Heart rate is more than 150 to 200, 250. There is a prolonged QT, may be congenital, may be acquired. Usually non-sustained runs of a polymorphic ventricular tachycardia. There will be always a sequence of short, long and short QT between RR interval before trigger response, which triggers into polymorphic ventricular tachycardia. Same thing is shown here. This is a polymorphic ventricular tachycardia, and commonest cause of polymorphic tachycardia is myocardial ischemia. Torsades De Pointes is a variety of ventricular tachycardia where multiple ventricular foci resultant into the QRS complex of varying amplitude, axis and duration. So rate more than 250, irregular, P wave are not seen, as P wave are not seen, there are no PR interval, QRS complex are bizarre, and Torsades De Pointes may terminate into ventricular fibrillation or asystole. Frequent causes are drugs that prolong the QT interval, electrolyte imbalance, mainly hypomagnesemia is the commonest cause. There are some risk factors for Torsades De Pointes. Very common in the person with older age, particularly more than 65 years, bradycardia, congenitally long QT syndromes or genetic polymorphism, diuretic, particularly which is producing hypokalemia, hypomagnesemia, Some electrolyte imbalance, particularly hypokalemia, hypomagnesemia, hypocalcemia, more common with hypomagnesemia and hypokalemia rather than hypocalcemia, more common in female as compared to male. Genetic predisposition, because some of the times it is a congenital long QT syndromes. Some of the cardiac conditions like myocardial infarction, congestive heart failure, left ventricular failure, etc. with severe reduced ejection fraction. Hepatic drug metabolism impairment, particularly which increases the chance of long QT. And some of the drugs which are very commonly known to produce long QTs are quinolones, and if QTC is more than 500 milliseconds, the chance is more. QT prolonging drugs, there are good number of drugs which prolongs the QT, as well as rapid infusion of certain drugs. QT can be prolonged. Person with CKD, AKI can also have prolongation because of the drug interaction and excessive accumulation of the drugs in the blood, or if the person has undergone cardioversion. This will be all the risk factors for Torsades De Pointes. Here are some example: hypokalemia, hypomagnesemia, hypocalcemia, hypothermia. This comes topmost on the list. Then myocardial infarction, restoration of the spontaneous circulation post cardiac arrest. This is another very common. Good number of time in a raised intracranial pressure, congenital long QT syndrome, medicines, drugs, congenital long QT syndromes. And among the drugs, azithromycin, particularly erythromycin, amiodarone, sotalol, tricyclic antidepressants, fluoroquinolones, etc. are known to produce long QT. So these are good number of drugs. You can see a big list: macrolides, fluoroquinolones, antiarrhythmic drugs, antifungal drugs are also notorious. So do keep this thing in mind. These are all the other drugs, a big list of a drug. Of that, very commonly we utilize azithromycin, erythromycin. Those are the common drugs. Cisapride, then procainamide, amiodarone, and among the electrolyte imbalance, hypo, magnesium, calcium, potassium, temperature, hypothermia, subarachnoid hemorrhage, intracranial hemorrhage, and congenital long QT syndromes. Do not forget all those conditions. Even quinidine is also notorious to produce long QT. Lithium is another. So these are all the different types, whichever way you want to remember. These are different mnemonics. So Torsades De Pointes is prolonged QT followed by a polymorphic ventricular tachycardia. This is little bit in detail regarding the pathogenesis and clinical findings. So you have got a long QT, and long QT is followed by a Torsades De Pointes, that is polymorphic ventricular tachycardia, which can be non-sustained and can go into ventricular fibrillation. Non-sustained, good number of time it is asymptomatic. Some person may complain of palpitation, and sometimes they can present as a syncope. And then in between it will be absolutely normal sinus rhythm, but you can see prolonged QT. And the person who goes into ventricular tachycardia, and if it goes into ventricular tachycardia and not treated, there can be sudden cardiac death. So this will be common way of presentation as far as Torsades De Pointes is concerned. So very frequently it is a short lasting, self-terminating, may be associated with hemodynamic instability and collapse, and may from polymorphic ventricular tachycardia can degenerate into ventricular fibrillation. And very frequently we have already mentioned all those etiology, that is electrolyte imbalance and congenital long QT syndromes. So again, polymorphic ventricular tachycardia, long, short, short, long, and then short QT followed by suddenly triggered by R on T phenomena and polymorphic ventricular tachycardia. Diagnostic approach to polymorphic ventricular tachycardia: patient with polymorphic ventricular tachycardia, arrhythmia terminated spontaneously or after defibrillation, obtain a ECG in a sinus rhythm, and if there is a long QT syndrome, then it is in favor of Torsades De Pointes. Now, in that, is QT prolonged prior to polymorphic ventricular tachycardia? If answer is yes, congenital long QT syndromes. And if QT prolongation you are not able to make out, always try to rule out acquired groups. And if there is no QT prolongation seen, this is not Torsades De Pointes, you should look for other conditions like acute myocardial ischemia, cardiomyopathy, Takotsubo, idiopathic polymorphic ventricular tachycardia, or catecholaminergic ventricular tachycardia. And in that, you will have to rule out ischemia, cardiomyopathy, and drugs that can produce such conditions. In this ECG, you can see a polymorphic. No, this is almost monomorphic. This is a monomorphic ventricular tachycardia. There is no change in the axis. Monomorphic. Here you can see, yes, ventricular bigeminy. Here, yes, this axis is going on changing. This is Torsades De Pointes. This is alternate beat is ventricular premature beat. So it is a bigeminy. So this is ventricular bigeminy. And then it is going into polymorphic. You can see here the axis is changing. So this is Torsades De Pointes. Here alternate beats. So bidirectional. This is polymorphic ventricular tachycardia. This is Torsades De Pointes. As far as treatment part is concerned, treatment is directed with the withdrawal of the offending drugs. So whichever, if it is drug induced, you have to stop that drug. Main treatment is infusion of magnesium. You can use an antiarrhythmic drugs to bring back to normal sinus rhythm. Mainly lidocaine is very commonly utilized. If it is secondary to ischemia, treatment of ischemic heart disease. If it is an electrolyte imbalance, then try to correct that electrolyte imbalance, mainly magnesium, hypomagnesemia, hypokalemia, and very rarely hypocalcemia. If person does not respond, then defibrillation must be done. Because of polymorphic nature, the Torsades De Pointes synchronization cardioversion may not be possible, and patient may require an unsynchronized shock, or what we call as a defibrillation. So by and large, it is an unsynchronized shock, what we call as a defibrillation, should be done. So search for the etiology and try to treat. If it is hypokalemia, potassium infusion should be given. Magnesium 1 gram over 2 to 5 minutes, maybe repeat one dose and may see the immediate effect. Another drug which is commonly utilized is isoproterenol. You have to start with 1 microgram per minute and titrate slowly until the ventricular tachycardia suppresses, or then you can go for 5 microgram per minute, and heart rate you should bring it down below 120 per minute to suppress ventricular tachycardia, or you can use overdrive pacing. So prompt defibrillation for unstable patient is a must. IV magnesium is very, very important, or you can go for lidocaine, or you can go for isoproterenol. Congenital tachycardia, congenital long QT syndromes, you can use beta blocker, or you can use the permanent dual chamber pacemaker, or you can go for sympathetic denervation, or you can use cardioverter defibrillator to prevent sudden cardiac death. So temporary pacing can be utilized. You can use isoproterenol if temporary pacing is not available, and you can initiate prompt defibrillation in an unstable patient. If person has got a recurrent polymorphic ventricular tachycardia, that is Torsades De Pointes, and if person is unstable, then electrical cardioversion is a must. If person is stable, then you can go for magnesium, potassium, or other treatment. That is, in an unstable patient, straightforward defibrillation, and in a stable patient you can go for magnesium, and if required again defibrillation. Magnesium infusion if GFR is more than 30 ml, and if GFR is less than 30, then you have to check properly, and then accordingly you have to use the magnesium loading dose. And if the person has got a recurrent Torsades De Pointes and if he is unstable, defibrillation is first, followed by lidocaine infusion and magnesium. So first line as far as recurrent is concerned, magnesium, or you can go for antiarrhythmic drugs. You can use isoproterenol, overdrive pacing. This will be for recurrent. And as far as the magnesium goal is concerned, initially 2 milligram per deciliter. Potassium goal 4 milliequivalent per liter. And this will be the way you use magnesium. This is in detail regarding the magnesium infusion protocol, loading dose, monitor of electrolytes regarding magnesium and potassium, clinical monitoring, and then when you should stop magnesium after 24 hours. At your leisure time, you can go through. Now, before all this treatment, rapidly you should assess the VT morphology. If it is monomorphic, depending on the stable or unstable, accordingly the treatment should be decided. And in a poromorphic, normal QT and prolonged QT. In a normal QT, emergency revascularization in an ischemic heart disease. If it is due to drugs or other conditions, antiarrhythmic drugs can be utilized. And when the person is stable, beta blocker is a common. While in a long QT, unstable, first defibrillation followed by magnesium, potassium, stop offending drugs, avoid certain trigger drugs, isoproterenol, overdrive pacing, etc. So that should be the method. So if there is structural heart disease with polymorphic ventricular tachycardia, then you will require drugs. And if there is a catecholomonergic polymorphic ventricular tachycardia, flecainide is a drug of choice. In a Brugada, quinidine and isoprenaline is a drug. Acute treatment for sustained polymorphic ventricular tachycardia, always defibrillation, or we call cardioversion, and then you can go for beta blocker, etc. Particularly with prolonged QT, remove the correcting drugs or what we call is a precipitating factor, avoid that, magnesium, overdrive pacing, beta blocker and lidocaine therapy in a refractory variety. So prevention, withdrawal of offending drugs, correct the underlying electrolyte abnormality, intravenous magnesium, cardiac pacing and isoproterenol infusion if temporary pacing is not available. So I end my lecture here. If you like this particular lecture, please don't forget to press button like, subscribe, and do not forget to press bell icon so that you get notification whenever a new lecture is uploaded. If you feel that this lecture is helpful to you, you can share with your friends also. Thank you for taking out time. I know that your time is valuable and I appreciate you for spending some of the time with me. All this material is gathered from YouTube's, Google, different websites, different CMEs, etc. And all my video lectures are mainly for educative purpose. You must contact an expert while treating a person with Torsades De Pointes. This is just for educative purpose only. So see you in next lecture.